I'm a second-year internal medicine resident from UTRGV NAP Medical Center. Today I'll be presenting a rare case of Tolosa-Hunt syndrome, the mystic cavernous sinus disorder. This is my outline. Moving on to the introduction, Tolosa-Hunt syndrome is a sporadic disorder that is recognized by the National Organization for Rare Disorder. It has an estimated annual incidence of 1 case per million per year. It is characterized by severe painful ophthalmoplegia that is believed to result from idiopathic granulomatous inflammation of the cavernous sinus. Though it's considered benign, permanent disabling neurologic deficit can occur if prompt diagnosis and treatment is not instituted. Moving on to the case presentation, our patient is a 59-year-old gentleman with history of diabetes who came to the ED due to 3-day history of right-sided retroorbital headache that escalated in a thunderclap fashion about an hour before presenting to the ED. On his way to the ED, he observed double vision and that his right eye was hanging down and out. Initial evaluation revealed normal vital signs and right-sided pupil-sparing cranial nerve 3 palsy. All other neurologic and systemic examination was essentially normal. Our initial suspicion was a possible subarachnoid hemorrhage, cavernous sinus thrombosis, or an ischemic diabetic mononeuropathy. Patient underwent an extensive neurologic workup, including CT scan, MRI, and venograms, which were all initially deemed normal. Patient continued to experience intense pain, and we initiated him on a trial of migraine cocktail, which did not improve his pain, as well as opioid, which also did not improve his pain. This prompted us to reevaluate his imaging studies, and that was when we noticed that the right cavernous sinus is markedly thickened and significantly enhanced on contrast enhanced MRI of the brain, and the homogeneous enhancement is also noticed to extend towards the right orbital apex. We suspected Tolosa-Hunt syndrome and initiated patient on oral prednisone therapy. The headache completely resolved 3 hours after initiating oral prednisone, and the neurologic deficit started to improve approximately 18 hours after initiating oral prednisone. This was the patient with complete ptosis prior to initiating steroid, and this was the axial view of the brain MRI showing right-sided cavernous enhancement with some extension toward the right orbital apex, and this is the patient 18 hours post initiation of steroid. The ptosis is improving, the headache has completely resolved. Moving on to the discussion, how do we make a diagnosis of Tolosa-Hunt syndrome? Tolosa-Hunt syndrome is a diagnosis of exclusion. Certain criteria has been recommended by the International Headache Society, which include presence of unilateral headache and ipsilateral ophthalmoplegia, ipsilateral MRI findings or biopsy findings to suggest granulomatous inflammation on the same side of the headache and ophthalmoplegia, and exclusion of all other possible differentials. And if a patient meets all these criteria, the sensitivity is 95 to 100%, and if they respond to steroids, that essentially confirms the diagnosis, which is the case of our patient. In conclusion, why did we decide to present this case? First of all, you want to increase the awareness about this severely debilitating neurologic disorder. And secondly, we also want to show that this is one of the rare causes of reversible neurologic deficit, and this might give patients hope of returning back to their premorbid functional status. Thirdly, we also want to share the pivotal role that steroid therapy plays both in the diagnosis and treatment of this condition. And fourthly, we want to emphasize the need to always rule out life-threatening conditions that can present like this whenever you're encountered with a patient with such presentation. And in addition, not to forget other rare conditions that can also present like this in order to decrease time to diagnosis, to decrease time to treatment, and also decrease patient suffering and morbidity. These are our references. We would like to thank our patients as well as the neurologists that helped us in demystifying this case. Thank you.